Hello, and a warm welcome to this professional education series webinar from Voice. My name is Jamie McGeechan. I am the Events and Sponsorship Coordinator of Voice, and I'm delighted that you can join us today. Our topic for this afternoon's webinar is eliminating elderspeak through compassionate communication, and we'll be joined by guest presenter Dr. Maurya Cockrell. But first, thank you kindly to our sponsors for the 2021 Education Series. We are very grateful for our sponsors' support that assists us in bringing this education to the long-term care community. And now to our presenter for this afternoon's session, Dr. Maurya Cockrell, founder of Why Not Consulting and the founder of Elderspeak Healthcare. Dr. Cockrell holds a bachelor's in health management from St. Louis University, a master's from Webster University, and a doctorate in health professionals education from Logan University. Additionally, Dr. Cockrell is a board member for Voice, and we're very fortunate to have such a passionate supporter, educator, and advocate. It's a pleasure to introduce Dr. Maurya Cockrell.
Well, welcome everyone, and I'm so happy that you're able to join us this evening as we discuss elderspeak and looking at eliminating elderspeak through compassionate communication. Understanding elderspeak as a type of biased communication is vital to prevent future ageist behavior towards our older adult patients and thus improve health outcomes. Elderspeak is most commonly found in long-term care settings, and it has been identified as a growing barrier between our older adults and our younger providers. It's important that we practice effective communication practices to make sure our patients are adherent to treatment plans and that we're able to build trust between providers and patients. Health communication and cultural sensitivity training are crucial for our incoming young health professionals. As boomer clinicians age and retire, they will be replaced by younger millennial providers and soon to be Gen Z. So these young providers will need to learn how to navigate the intergenerational relationships with their new boomer patients. So our learning objectives for today, first, we're going to define what is intergenerational communication. Then we're going to explore intergenerational healthcare. Next, identify ageism. Then look specifically at elderspeak. Next, compare and contrast elderspeak and compassionate communication. And then I'll leave you with some best practices for compassionate communication. So I always like to start with my lens, especially when doing diversity and inclusion training. So I am a Black millennial female. I'm considered an academic entrepreneur. And I'm also a trained elder doula and grief walker. If you haven't heard the term grief walker, it's another word for death doula. So I want to give you my lens so you kind of understand our perspective. When looking at DEI training, it's important to understand your own lens and your own bias because we all have bias and it's good to be aware. That way we don't contribute to negative stereotypes. So that's just a little bit more about me. So what exactly is intergenerational communication? It's verbal interactions that vary between members of different generations, and intergenerational communication is all around us. It can be between a grandparent and a grandchild, you and your parent. Most likely in your work environment, you're constantly having intergenerational communication. So again, it can occur in your home, in your school, in your church, or even in your community. And it's really looking at how to best create relationships between the generations. And you need to have excellent communication to do so because the different generations have varying experiences that shape how they communicate and their preferences. And in a few more slides, we'll get into the different generations just to level set to make sure everyone knows who we're interacting with, who might be our future patient, or even our older adults that we're working with. So it's good to understand the possible stereotypes and biases out there so we can create a new mindset of improving these intergenerational relationships through communication. So we'll look at societal expectations and different events that have truly influenced each generation. So right now, there are 6 living generations. And if you know your generation, definitely go ahead and share in the chat, tell everyone hello, but we'll go into each one so we can understand, how elderspeak can occur and what are the different communication practices between the generations. But definitely get involved and share your thoughts on intergenerational communication and your experiences. So first, we're looking at the traditionalists. Now, there might be varying years depending on what research you're looking at, but most likely traditionalists were born between 1946. You might have heard some other names like the silent generation or GIs like G.I. Joe and G.I. Jane. This generation was shaped by World War II. Some assets for this generation are respectful, loyal, dedicated, and discipline. So I want you to definitely think of the assets and even the liabilities, have that in mind as we go through today's session to figure out what might the stereotypes be and kind of get a sense of how elderspeak might have formed. And thank you for sharing in the chat. I see we have some boomers in the audience with us. Okay, perfect. Some liabilities. Now, again, every person is different and we need to respect individual differences, but I just want to give you some parameters when thinking about the different generations. So liabilities for traditionalists, it could be dislike change, some stereotypes, maybe a little rigid, stubborn, risk-averse, and can be closed-minded. Now, again, we have to understand what stereotypes are out there to make sure we can combat it through compassionate communication and positive intergenerational relationships. So I'm not sure if we have any traditionalists on the call, but if so, definitely say hello in the chat. Next, we have boomers, and I know we have some in the audience today. So boomers were born between 1946 and 1964, also maybe known as the Me generation. Boomers were shaped by Vietnam War and civil rights. Some assets, competitive, optimistic, ambitious, and competent. So definitely when thinking about boomers in the workplace, the ones that probably beat you to work and might be saying a little bit later, definitely dedicated and optimistic. Some liabilities, possibly self-centered and a little judgmental. Some stereotypes can be power hungry or workaholics. But again, it's good to understand what research is out there, the perception that people have, because today is all about learning what these stereotypes are to then figure out how to eliminate elderspeak. Next, we have Generation X. So Generation X is born between 1965 and 1979. And some other names are post-boomers, Xers, and even the doers. Some major events, the stock market crash, different assets can be independent, creative, entrepreneurial, or even pragmatic. Some liabilities, possibly impatient, cynical, or mistrusting. But again, look at the major events that shape them. The stock market crash, you can kind of understand why the mistrust might come for corporation or other things like that. Some possible stereotypes, slackers, wannabe, and cold. Now, again, just teaching you about the different generations, the literature that's out there, but I'm going to be a little biased. I have some Gen X cousins and I can kind of see where the stereotypes come from. Next, my generation, the millennials. So born between 1981 and 2000. Some other names, Gen Y, Sunshine Generation, or even Chief Friendship Officers. So if there are any millennials in here, definitely say hello in the chat. I see we even have a Gen Z I will get to in just a few. Major event shaped by 9/11. And I know we recently celebrated the anniversary of 9/11, acknowledging that. I remember where I was, and that's something that most millennials can pinpoint that day in history that shaped them. Some assets, tech savvy, collaborative, fast pace. Some liabilities, impatient, have helicopter and lawnmower parents, and a distaste for menial work. So I'm gonna pause and go a little bit deeper just to explain what a helicopter and lawnmower parent are, in case you don't know. So for millennials, they get the bad rep that they need their parents around the 24/7. Helicopter parents, which can be Gen X or boomers, are there hovering if a millennial falls or makes a mistake, maybe there to pick them up, console them. My background working in HR, even having some millennial parents call if the person didn't get the job, that's an example of a helicopter parent. Lawnmower parent is the parent that tries to remove any obstacle, making sure that their millennial child never experiences any hardship. So that's just a little bit more about just how that generation was shaped. Some stereotypes that I know I've heard: entitled, spoiled, disrespectful, and inexperienced. So again, I know the good and the bad that comes with being a millennial, but it's a good thing to understand, especially in this context of looking at younger providers. The older adult patients or even other generations might have these stereotypes when you're walking in the door. So it's good to understand what their frame of reference might be so we can help combat these negative stereotypes. Next, we have Generation Z, and I know we have one in the audience. So born between 2001, 2010, some other names: NetGen. Major events, unfortunately, shaped by mass shootings, which is something that we definitely experience here in the United States. So just having the constant drills or fears of being in school or going to concert and movie theaters, unfortunately, those events help shape this generation. Some assets: hyper-aware, 40 thinkers, flexible and motivated. Some liabilities: and be less focused and expect a completely digital organization. So looking at these providers, when they're Gen Z, they might want to use more health information technology with their patients. That's an expectation when they're coming into your workplace. And again, feel free to share your thoughts in the comments as well. Some stereotypes: attention seekers, lazy, and the TikTok generation. Now, again, these are general stereotypes. I personally have a TikTok, probably not as skilled as a Gen Z, but still something to think about. And next, we have Generation Alpha. We're still gathering a lot of research on Generation Alpha, but looking at the years from 2011 to present, some other names: the onliners, global generation, the technos. Major events for especially the younger Gen Alphas: COVID. So assets: thriving in diversity, just growing up in a time where there's access to everyone across the cultures, having that experience. Some liabilities: some unfamiliarity with in-person socialization. So that is something to think about and to keep in mind as this generation ages and soon will also become healthcare providers. Some stereotypes: possibly hating the rules and constantly changing. So again, go ahead and share if you have experienced any of these stereotypes, if you feel any of this is applicable to you. Definitely want you to get engaged. So looking at intergenerational communication, I just want to go over a few best practices and things to be mindful of when you're looking at communicating across the various generations. So some generations might prefer to communicate via phone. So for example, if you're a healthcare provider, possibly working with the boomer traditionalists, phone call reminders or phone call communication with their healthcare providers. And on the other side, some researchers say with millennials, maybe preferring text messaging. I know, myself included, I would prefer a text asking, are you available for a phone call, instead of a phone call. But again, no matter what, it's good to learn who your patient is, who your resident is, and learn their communication styles. Because again, these are just some frameworks and ideas to think about when trying to improve intergenerational communication. Another form of communication is email. This style is usually preferred by Gen X. So something to think about if something can be sent in an email or a text message. And what's not on this slide, but still relevant, is snail mail. Sometimes it's okay to still send letters. Not everyone wants electronic version, medical records or updates or billing statements. So definitely keep in mind the different ways that you can communicate across the generations and understand what their preference might be. Next, again, just looking at how to best communicate when working with generations that might prefer shorter communication style, paying attention to what can be a text, what can be an email, and even the layout of the information, especially if you want someone to read it completely. So something as simple as looking at the subject line or the to, who you're CCing, and even using bulleted information in the email to make sure you're best communicating your message in a way that that generation might receive the information. So feel free to put in the chat or share, what is your preferred communication style? Again, I am a millennial and I do prefer text message, but that might not be for everyone. But I also am a millennial that owns stamps and envelopes and still use snail mail. So it really just depends on who you're working with. Oh, Adderall. So just looking at Adderall, how fast someone's reading it, looking at the message, a way of saying, hey, making sure it's nice, short, sweet information that you can speed through and speed read. So hopefully I answered that question for you. Okay, so phone calls and email. Perfect. So looking at intergenerational healthcare. So by the year 2029, the youngest boomers will be reaching retirement age, bringing the total number of Americans aged 65 and older to 71 million. So of course, as boomers age, more millennials will be entering the healthcare workforce. And it will be very important to understand the health outcomes of this boomer generation and know that a lot of it will be based on the communication that they have with their providers. Now, looking at the events that shape the generations, we understand that boomers and millennials have experienced different social climates, economic climates, political climates that all shape how they communicate and how they interact with one another. And this information is definitely helpful for the patient-provider relationships and really understanding what is your resident or patient's beliefs, practices, and behaviors. And so when looking at intergenerational healthcare, it's important that our residents and our patients truly trust the providers and provide that non-judgmental care. And that's why it's good to have that understanding of the stereotypes and the biases to make sure that we can all come together to really create a great intergenerational healthcare environment. And thank you for still sharing in the chat. It can depend on the mood, on the person. So again, it's good to get to know who you're communicating with, who you're serving, and what are their preferences. And it's better to ask than assume. So specifically looking at intergenerational healthcare, there can be potential differences in the patient preferences. For example, think about the slides before, the different communication styles or the events that shape them. Depending on the generation, some might prefer telehealth versus in-person visits. I know surveys done for millennials say they seek telehealth, but they also want provider connection. So looking at the second bullet point, having that need for a provider-patient connection, having that trusting relationship, but that might look different depending on the generation. So again, that can come through telephone, telehealth, video conferencing, or sometimes some providers are providing tech support, especially when it comes to mental health. There can also be differences when it comes to the need for physician guidance. It is, if you think about the traditionalists and the boomers, thinking about the events that shape them or the characteristics, some might look more to their provider for recommendations or best practices or believe whatever the provider says is gold versus, say, millennials or Gen X using Dr. Google and then coming to the provider with questions or said, oh, I think I have this or XYZ. So it's something just to be mindful and aware of that there might be differences or patient preferences because of the generation. But again, it's good to get to know who you're working with, who you're serving, and what type of relationship you can build with them and through what communication means. So now looking at ageism. So unfortunately, a report from Health Leaders Media reported 1 in 5 adults report age discrimination in healthcare. And about 1 in 17 say that they experience it frequently. So this is something that older adults who are age 50 and older are unfortunately experiencing in our healthcare environments. And some experience that they have more age discrimination when they have a new disability or a worsening disability. So it's something to think about, that ageism is real, it is out there, and it's important that we understand what signs to look for and what exactly ageism is. That way we can work as healthcare providers and community members to advocate for those older adult patients. So understanding what ageism is, and we can run the risk of just promoting negative stereotypes and biases. So looking at the definition of ageism. So ageism is a prejudice in which people are categorized and judged solely based on their chronological age. So this is pigeonholing them and not allowing them to be their individual, unique selves, just looking at their chronological age. And like I mentioned, we have, unfortunately, ageism in healthcare, and there is little interest in geriatrics. There are only 7,000 geriatricians practicing in the United States today. That number is extremely low. And the American Geriatrics Association said in order to meet the demand of the aging boomers, they would need to train an additional 6,250 between now and 2030, just to make sure there's enough for the aging population. But unfortunately, a lot of healthcare providers, and I know the millennials in my network, are looking to specialize in other industries and not focus on geriatrics. So it's something to think about when figuring how we can best take care of this population. So now I want to specifically look at Elderspeak. You've understood what intergenerational communication looks like, what it looks like in the healthcare landscape, and knowing that ageism exists and how frequently it occurs. But looking at exactly what is Elderspeak. So Elderspeak is an adjustment a person makes when addressing someone older. It's a condescending way of speaking to an older adult that truly resembles baby talk. So remember, this is if you're talking to an older adult and you change your tone or pitch just because of their chronological age. For example, Elderspeak is using a sing-song voice or changing your pitch or tone or exaggerating words. So for example, if I'm talking to my friend and I say, "You look so beautiful, I love your outfit." Now I'm talking to someone older, I'm saying, "Oh my goodness, you look so cute in that outfit. Oh my gosh, you look so great for your age." Did you hear the change in my tone, my pitch, how I was saying the words? There should really be no difference. If the outfit is beautiful, it's beautiful. I don't need to talk in a baby-like tone to someone just because they're older. And it's that purposeful change in that communication. It can also be simplifying the length and complexity of sentences, or speaking louder or slowly and yelling at someone like, "Oh my gosh, Miss Sue, how are you today?" At least check to understand, do they need you to speak louder? Are they not understanding what you're saying? Instead of assuming just because they're older, they can't hear or you need to speak louder. Also, using limited vocabulary. For example, my specific research, I looked at Elderspeak and simulated encounters. And noticing Elderspeak, the healthcare providers who were millennials were saying phrases like going number one and going number two. Now, that is something that you would say to a child, not to an older adult that clearly understands what it is to go to the restroom or the need to go to the bathroom. Using that limited vocabulary that you use with a child is another example of Elderspeak. It can also be repeating or paraphrasing what has just been said without checking for understanding, or even using terms like honey and dear. And I'll go into what those specific examples are in a little bit. And also using statements that sound like questions. So just hearing what is Elderspeak, I'm curious in the chat, have you experienced it? Have you witnessed it? Yes, there are some studies that look at Elderspeak for older adults in dementia, and looking at using Elderspeak for patients with dementia causing more lower self-esteem, or just having a worsening effect on their health. So yes, they are looking at specifically Elderspeak with dementia and Alzheimer patients. So that is good to call out. So I want to go specifically into the 4 categories of Elderspeak that have been found in research. The first is a diminutive, and that's the modification of a word or name to make it short and small, like childlike terms of endearment. For example, when I was saying honey or dear, my name is Maurya, and if I was an older adult and someone automatically shortened it to Mari or Mar without asking, that is an example of diminutive. Next is collective pronoun substitution. It's using a collective pronoun when a singular pronoun is important. So for example, thinking of the long-term care environment, a provider says to a resident, "Should we eat our dinner now, Miss Lucy?" When the correct term should say, "Are you ready to eat dinner, Miss Lucy?" You know, you're not eating dinner with them. It's something that they would do individual on their own, but it's that slight change to we, like they're not able to do it for themselves. Oh, I see. Thank you for sharing in the chat. Definitely, you've heard the we in your work environment, so definitely sharing. Tag questions. So it's when you pose a question in a way that shows that you already have a preferred response. For example, you see, "You're ready for bed now, aren't you?" Adding that "aren't you" is the Elderspeak. You can ask, "Are you ready for bed?" But when you say "aren't you," you might make the resident or patient feel like, "Oh, I guess it's time for me to go to bed. I must be getting sleepy," or "I don't want to say no, I'm energized, I'm not ready," because clearly they're ready to probably put me in bed and clock out. So that's something to be mindful of. The last category of Elderspeak, reflective. So it's encouraging an act to satisfy the provider and not the patient. For example, it says, "Can you get in the bed for me?" That "for me" part is unnecessary. You could just say, "Can you get in the bed? Can you do XYZ?" You want to make sure that you're promoting and encouraging patient autonomy and letting them know that they are able and capable of making these decisions for themselves. Elders are being called Mr. or Mrs. I think that is good. I know I was raised to say Mr. or Mrs., and it's also just the best practice to ask, "How would you like me to address you? What is your preferred name?" And that's something that truly transcends all DEI training. Asking preferred pronouns or names is something that we just need to communicate with and figure out what is the preference for those that we are serving. So how common is Elderspeak? We already learned that ageism exists, and it exists heavily in healthcare, but Elderspeak is extremely common in nursing homes, hospitals, or other settings where they say frail elders are to be found. When I was doing my research, all the articles were done in the nursing home setting, and I chose to do it in another population just to see if it exists. And Elderspeak is unfortunately everywhere. And again, it's that speech pattern that's based on stereotypes and looking at that person's chronological age, but not looking at who they are as a person. So it can occur in banks, in grocery stores. Through my research, people have told me they've experienced Elderspeak at restaurants, saying honey, dearie, sweetie, without asking them. So it's something that we're looking at in healthcare, but honestly, it's happening across our society. So what exactly is the harm in Elderspeak? So again, when looking at those intergenerational patient-provider relationships, we want to make sure that we focus on mutual trust, and that trust is the foundation. So it's important that, the patients feel comfortable with their provider so that they can be honest. And when you have Elderspeak, it can imply that an older adult is not competent or able to make decisions on their own. Or if miscommunication occurs, they might feel like that it's his or her fault. And again, we want to advocate for our older adults and empower them to make their own decisions. But Elderspeak can also make an older adult feel like they need to reevaluate their own abilities. If someone is talking to them like a child or a baby, they might start to think, okay, am I exhibiting a certain behavior? Is it something that I'm showing? Really second guessing themselves. And that is not ideal, especially when trying to build that patient-provider relationship. And of course, Elderspeak is reinforcing those negative stereotypes about aging. It's all about shifting our mindset for positive aging, looking forward to getting older, because it is a blessing to age and get older. And when we use terms like Elderspeak or baby talk, it reinforces those negative stereotypes that as we age, we're automatically declining or losing our senses, our abilities to communicate, and that is not what we want to do. And again, it can erode older adult self-esteem. And we want to make sure that we are promoting positive aging, especially in the long-term care community, because it's such a sensitive population. But we need to work to build that relationship between the patients and providers. So yes, Elderspeak is everywhere, but it's very important for healthcare providers to get the training to know that most times they don't even see the harm in it, or might feel like, well, I was raised this way, to say, sweetie, dearie, ma'am, and not knowing that it can negatively impact an older adult's self-esteem. In my own research study, talking to older adult patients, knowing that Elderspeak is a term and that exists empowered them to stand up for themselves and educate others, saying, you know what, I would prefer if you called me XYZ. Did you know you probably don't mean any harm in it, but what you're saying is actually Elderspeak. So that is something that we want to make sure our healthcare providers are trained on, and even our residents and community members, so that they can advocate for themselves. Because if our healthcare providers are displaying Elderspeak, then that will lead to judgmental relationships. And the worst case scenario is that your patients or residents aren't feeling comfortable to tell you exactly what's going on, or maybe not being honest about taking their medication, or accurately reporting symptoms, or even discussing their choices and behavior because they have the fear of being judged. So it's definitely important to think about, because there is the link to the self-esteem, but also the health outcomes. So again, what does Elderspeak look like in conversation? And again, is the shortened speech, can be slower, can be using a high-pitched tone. But again, Elderspeak is the meaning. It minimizes and assumes a lack of competence and a lack of power. So for the first example, a nurse comes into a senior patient's room and says, are we ready to potty? Instead of saying, use the restroom, or do you need to go to the bathroom? And in this example, there are actually two types of Elderspeak. And just curious if anyone is able to kind of guess what might be wrong with this sentence, or what type of category. Again, we have diminutives, collective pronoun usage, tag questions, and reflective. And getting you warmed up, because we do have a short quiz next. Perfect. Thank you, Donna. We and potty, using that collective pronoun, and potty as a diminutive instead of saying use the restroom. So it's looking at number 2. How are you today, young lady? A medical assistant says to a 90-year-old resident. The young lady part is unnecessary, and it almost seems as a joke, talking to someone who's clearly 90 years old, calling them young instead of calling them by their name. So that is another example of Elderspeak. And then last, it's not exactly said to a resident or a patient, but a staff member at an adult assisted living facility watches participants in the game room and says, aren't they just adorable? Now, you know, this is not being said to the resident or the patient, but is still being said to another staff member, which contributes to these negative stereotypes about aging in older adults. So even if you're just saying it to your friends, your families, it's something that we need to be mindful of and to stop, because we need to work on that mindset of positive aging. So we already got a little warmed up, but I do have a quick quiz. So definitely keep sharing in the chat what you think the answer might be. And again, just go ahead and guess and try, because I just want to make sure you know what Elderspeak is so you can recognize it. Because once you recognize it, that's how we can start to eliminate it. And again, thank you for sharing. Yes, we have to be aware what we say around to others, especially, again, you never know who's listening. It might not be the patient or the resident, it could be their family member that can make them feel uncomfortable. Personally, I got into this research because my grandmother experienced elderspeak. She was older and had breast cancer, and her provider felt because she was over 70 that her life was already over. So hearing that elderspeak broke my heart and made me feel awful for my grandmother. So again, good point. You just never know who might be around and how that might impact them. So looking at number 1, go ahead and just type in the chat, what is the exact category of elderspeak? Sweetie, you're just so cute. Is this a diminutive, collective pronoun usage, tag question, or reflective? Go ahead and let me know in the chat what you think the correct category might be. Okay. Perfect. Yes, it is diminutive. The sweetie, and you're just so cute. And depending, you heard how I read it out loud, but yes, diminutive because possibly using that sing-song voice. That sweetie, you're just so cute. I wouldn't say that to my friend. I would say, oh, I love your outfit, or you look so cute. That purposeful change in the way I'm speaking is the elderspeak. And also asking or saying sweetie, unless that's the resident or patient's nickname and they told you that's their preferred name. The next one, are we ready for dinner yet? Now, again, think of this in the mindset of the long-term care community. Okay, I see it, B in the chat, and that is correct. Collective pronoun usage. You should be asking the resident, are you ready for dinner? Would you like me to take you to the eating room now? Definitely something that's not a we activity, most likely not a we activity. So perfect, great job. Looking at the next one, can you take your medicine for me? Is this a diminutive, collective pronoun usage, tag question, or reflective? Okay, I see someone put C in the chat. Any other guesses? Tag question. Okay. So this one is actually reflective. It's the for me part that's the issue in the elderspeak. You can simply say, can you take your medicine? Did you take your medicine? The for me part is unnecessary because instead of saying for me, the healthcare provider should be educating the resident on why it's important to take the medicine. Taking the medicine is beneficial for his or her own health. So it's something to be mindful of and not adding because they don't necessarily need to do anything for you. The medicine is beneficial, so it's good to add the education, check for that understanding, and that for me is what causes it to be elderspeak. So then the next one is, you're sleepy, aren't you? What do you think that is? Is it diminutive, collective pronoun usage, tag question, or reflective? Okay, I see tag question, C. Okay. And thank you too for sharing your thoughts about the for me part. You just never know how that makes someone feel. Okay, so it looks like everyone's saying C, and that is correct. It's that aren't you. You're already showing what your preferred response is. That's saying, are you sleepy or are you getting tired? Now the person might think, oh my goodness, I yawned once. Now they're trying to put me in bed and lock me in my room. It's important to just think about, it's such a simple thing, but being mindful of how that might impact someone who is living in that long-term care facility or an environment where they already feel like they might be losing their rights or people aren't listening to them. So that is correct. We only have a couple more. The next one, can you turn over on your side for me? Is this diminutive, collective pronoun usage, tag question, or reflective? Let's see. Okay, I see D. Okay. Yes, that is correct. Reflective, that for me part. And I actually saw a lot of this type of phrasing in my elderspeak research saying, can you turn over on your side for me? And just thinking nothing of it, but that part is unnecessary and making someone feel like, okay, well, I can turn over on my side. I know you need to examine me, but not adding that for me. The next one, we did our stretching exercises, right? Again, is it diminutive, collective pronoun usage, tag, or reflective? We did our stretching exercises, right? Okay, I see B, B, C, C. So this one was a trick question. It is actually collective pronoun usage and tag question. The we and are exercises, but the right, because what if the person didn't do their exercises? Now you're causing an environment that might make them feel necessary to lie that they did the exercises. And again, as healthcare providers, we need to know the correct information, the behaviors and patterns of our residents, of our patients. But when you say right, it's already assuming that, okay, well, I should have done this and I don't feel comfortable, or I don't want to let my provider down if I didn't do my exercises, instead of being honest. But also the we and the are, unless maybe you're working in PT and OT and doing the exercises together. But in this example, this is an activity that the person will be doing on their own. So that's why it's also wrong to use that collective pronoun. And just our last two, you remind me of my Nana. Now, I know personally when I worked as an ombudsman, a volunteer ombudsman, I definitely heard some of this. So is this a diminutive, collective pronoun usage, tag question, or reflective? Okay, I see diminutive, I see D. So this one is diminutive, it's A. It's the Nana part. Now, most likely, again, the provider did not mean any harm by saying this, but just understanding that, okay, if someone might be feeling young, energetic, and you're telling them, oh, you remind me of my grandma, that can be offensive. And again, as I said in the beginning, learn your patient, learn your resident, learn how they want to communicate, how they want to be called, and build that relationship. But using phrases like this for others might be harmful. And the last one, be a dear and take this medicine for me, please. Saying it nicely, but what category of elderspeak do you think is in this last one? Okay, I see A and D. And they're A and D. Okay, you all are experts now. Yes, it is A and D. The be a dear, the dear part is the diminutive, and take this medicine for me, please, is the reflective. Again, that for me is unnecessary. You should be explaining why it's important to take the medicine, maybe educating on the harm of not taking the medicine, but for no reason should the person be taking medicine just to satisfy you, the healthcare provider. So everyone gets an A. I think you did a great job. And I know it's kind of easier since we just went over the examples, but start listening to conversations and even check your own speech. I'm not perfect either. I don't know if you know this, I'm trying to say boomers because through recent research, some individuals find baby boomers to even be offensive in elderspeak by adding the baby in front of it. So it's something that I'm always learning, trying to be mindful of to figure out how to best communicate with the people I serve and work with. So just wanting to give a reminder about some words or phrases to avoid, again, unless you have a conversation with your resident or patient and figure out if they want to be called by one of these nicknames. But looking at aged or elderly, like I just mentioned, baby boomer, that's something new, trying to switch to boomer to be more respectful. Honey hun, baby dearie, good boy, good girl, that one is definitely extremely offensive and unfortunately has been heard in a lot of nursing home settings when someone has turned over or taken their medicine or gotten in bed saying that good boy and good girl. That's something that you'll probably say to a pet. You shouldn't be saying to your patient or a resident. So I just wanted to give you this slide just to be mindful of some words that we often use and we often hear that research has found can lead to negative self-esteem and lower health outcomes for the older adults experiencing it. So now shifting to compassionate communication to figure out, again, eliminating elderspeak, what we just learned, and figuring out the best way to communicate with those we serve. So compassionate communication is a teachable skill. That's why we have training sessions like this. We need to work to help people remain empathetic. Again, it will be a blessing that we age. It should be something that we look forward to. So we need to have empathy for those who have already made it to those milestones and figure out how to best communicate with them. So compassionate communication is a way to hear people, their needs, their wants, respecting their opinions and wishes, even if it differs from you. And compassionate communication is crucial for patient-centered care. We want to make sure that we use those open-ended questions, that we're focusing on active listening, that we're making sure we're creating space for our residents and patients to tell us more about their lived experience and know that we have their best interests at heart, because this is the way to start building that trusting relationship. So again, looking at the empathy, the feeling, communicating the respect, the understanding, and support for those that we serve. And also just understanding, again, looking at the Elderspeak and the shift to compassion communication. Even if our residents or patients or clients have changes in hearing and vision that can affect how they communicate, that doesn't mean that they don't understand. So that's why it's always good to check for understanding, but also knowing facts about having compassionate communication and effective communication. It can help prevent medical errors because you have that trusting relationship. It can lead to improved health outcomes. Again, all of this goes back to trust, and compassionate communication helps build that relationship through the intergenerational relationships between providers and patients. So looking at, again, compassionate communication, know who you're serving. Figure out how to tailor comments and instructions to best serve that purpose. And I know this is easier said than done, thinking of insurance requirements and how much time you have with individuals, but try to be as mindful as you can to understand and focus on the person that you have in front of you. Be transparent, again, about the risk and benefits of treatment. We were looking at the reflective statement. So many times it said, take this medicine for me, do this for me. But you need to be transparent on why they need to do it. Again, what are the risks? What are the benefits? You never want your resident or patient taking medicine or doing something and they don't even understand why. They just don't want to upset you. And that's what we need to get away from. Also, offering advice rather than telling someone what to do. Explaining, again, the benefits, telling them why you think this is a good recommendation. Already mentioned allowing for open-ended questions, expressing empathy, and again, making sure we illustrate what respect and support look like. So even thinking about using that clear speech, waiting 5 or 10 seconds to check for understanding, use the teach back method. All of these are tools that you can use when looking at compassionate communication. And looking at it in practice. So we looked at Elderspeak, heard a lot of phrases, but here are just some other examples. It could be, is there anything you wanted to talk to me about today? Making sure you're leaving it open. So often we have the yes or the no, and that goes along with tag questions. In my research, people were saying, oh, you don't feel any pain, right? Or XYZ. No, leave space for your clients or residents to tell you what's going on. Or the example, you seem worried, or are you concerned? Is there anything on your mind? Those are other ways to say it better and saying, you're worried, aren't you? Or that could increase the worry for that resident or client. So using simple language and tailoring it just like this. Or I see why you're concerned about this. And another example, you've shown a lot of strength. Again, we want to eliminate elderspeak and use compassionate communication to truly empower those that we work with and showing them that you've shown a lot of strength, or I understand why you're frustrated, making sure you go back to empathy. And another best practice or compassionate communication is practice is to really plan out those conversations, make an outline of what you need to cover, what your individual resident or patient needs to understand, and then practice how to say it. Use role play. Like I said, I'm always learning, and you should always be learning and figuring out the best way to communicate with those at your place of employment or in your community. So again, wanting to leave you with a few more best practices for looking at how to use effective and compassionate communication and truly get away from elder speak. So allow that extra time, just making sure that there's the space in the room for your older residents or patients. And again, I know the healthcare environment can get so busy, but when you're in front of them, try not to multitask, try to be present, use that active listening. And this information is great for the healthcare providers, the caretakers, and those in the community, because again, we want to work on positive aging and that mindset. I know things are a little different right now with COVID, but when you're doing that direct patient care, sit face to face when possible, have that interaction, let them feel like you're the only person that's important right now and that you're focusing on their needs. In general, it's good to stick to one topic at a time. Check for understanding. Even looking at using written communication, you might say something verbally, but go ahead and reinforce it with a printout or a handout or writing a note. That way it's good not only for older adult patients. I know even me as a millennial, I would love to be able to reflect back. I might have questions later. So that's definitely a best practice. And then always respecting cultural diversity. And like I said, throughout the presentation, it's good to know the individual communication preferences of those that you're working with, but also understanding that elder speak can change depending on the person or the cultural background. Even through my research, looking at some of the diminutives, say in some of the South, that might be respectful, but understanding and knowing that the list that I provided to you, researchers have seen that some of these are found offensive for older adults that can erode their self-esteem. So something just to think about when you're building your toolkit of compassionate communication, definitely wanting you to learn a little bit more about elder speak and best practices. So I will go ahead and end it there and see if there are any questions or comments in the chat. I hope you found this helpful. I hope you learned something new about what elder speak is and kind of what are some of the tools and best practices to shift that mindset to compassionate communication. Because again, our population's aging, the providers are getting younger, and we need to do our part to make sure that we're not contributing to those negative stereotypes.
Thank you so very much, Dr. Cockrell, for an excellent presentation. Absolutely fantastic and so inspirational. If anyone does have any questions, please do enter them into the chat window or onto the Q&A section.
Thank you all too for participating in the chat and giving your feedback and experiences. Truly appreciate it.
You mentioned, Dr. Cockrell, that your own journey with Elderspeak and learning about it was inspired through the treatment that your own grandmother experienced. Are people that you educate, are they surprised or shocked when they realize the way they've been communicating with older residents is diminutive? Are they surprised?
I think people are surprised because it's very rare that I feel like someone's intentionally being harmful. I think it's just understanding that some people find the information, the wording offensive. Now, in my personal experience with my grandmother, I think the provider should have known what she was saying was offensive by telling her her life was already over. And yes, that is sometimes extreme case of ageism and elder speak. But most times when I've done training with millennial providers, they're saying, oh, well, I didn't know this could cause harm, or I didn't even realize I was saying we. I'm just trying to have them move over to their side. But now knowing it's like, okay, well, I can course correct. And like I said, we're always learning and not going to be perfect. But most are surprised that it seems so small, like the adding the right or the for me, but it can honestly make a huge difference. And I hope there's more research on it. Like I said, most of it has been done in the nursing home setting. I did mine in the chiropractic setting, but others who work in blue zone populations, seeing elder speak, like I said, at the grocery stores and see the effect that it has. Looking at blue zones, those who are living to be 100 years old plus in that respectful communication, looking at how areas like that have less elder speak, showing that respect for the older adult it's something to be mindful about for sure.
Absolutely. The power of language. Sometimes we don't even realize the inflections of the words we use or tailor them to specific or appropriate audiences, but everyone likes to feel respected and cared for, and sometimes it just takes that little bit more consideration. It's such a fascinating subject. If our attendees today would like to discuss the theme, the issues with you more, can they get in touch with you?
Yes, definitely. I see put my website in the chat, so that is great. I'm also on LinkedIn if you want to send me a message, but definitely all for sharing this information. I know, like I went to Spain to talk about Elderspeak. It's something that ageist behavior is occurring in healthcare across the globe. So it's something to be mindful of, but definitely feel free to reach out and get in touch because it's something that's so important to me because I witnessed it personally and I saw the impact it had on my loved ones. And I know that I never want anyone to feel the way that my grandmother felt. And that's why I do this research and training like this, just trying to bring education and awareness.
Absolutely, and you're doing a great job of raising that awareness. We've had a question there from Thomas Walther. Are the slides available as handouts? They will indeed be available as handouts, and the session is being recorded. We will send you a link to the recording for tomorrow. And then there's a comment there also from Donna Beck.
True. I mean, I think like you mentioned, ageism on top of kind of already the patient-provider relationship is adding another level, making it more difficult. I'm just thinking about the barriers that are already there. And again, just looking at patient-provider relationships, there's so much that goes into it aside from ageism, but adding that layer of focusing on that chronological age definitely just contributes negatively to the whole healthcare experience that our older adults are having.
Absolutely. If anyone else has any questions or comments, please do share. We've just got a few more moments of Dr. Cockrell's time. Dr. Cockrell is in Europe at the moment on tour presenting on Elderspeak. So we are honoured to have you regardless, but even more so at this time of night. So thank you.
No problem. Yeah, almost midnight, but just anytime I can talk about it and spread the awareness, I'm happy to do so. So I appreciate you having me.
Absolutely. Well, we're very grateful for your presentation this afternoon. If I can remind everyone who is online with us, at the end of the webinar, there will be a survey that will appear on screen. For those of you who are doing CEUs, please do fill in the survey. And for those of you who are not, we are very grateful for any feedback also. Any more questions, any comments, anyone?
I saw there was a question in the chat, so I just tried to answer that real quickly before we end this. What type of Elderspeak did you find was used the most? In my research specifically, it was collective pronoun usage, and that aligned with all the research in the nursing homes, using that we and our is the most common form of Elderspeak currently found in our healthcare setting. So hopefully I answered that question for you.
Well, once again, I would like to thank you very kindly, Dr. Cockrell. You're a fantastic advocate, educator, and passionate supporter of voice, and you're doing great work, and we're very grateful to you for your time. Thank you.
Thank you so much, and thank you everyone for joining.